How does that look?
Great.
Looks all right. Okay. All right. Well, thank you. Feel free to ask questions or interrupt as we go. I have a habit of kind of biting off more than I can chew with any kind of talk like this. This probably could be like a 2 hour talk. So I may go with some energy, like right up to like 12:50. So feel free to interrupt and ask for questions. I don't know if anyone can monitor the chat because I can't see it, but
Yeah,
feel
I
free
can
to
do that.
just wave or just break in, and that's fine. I don't get thrown off that easily. Like I said, I do have more here than is reasonable to cover, so I probably will skip quite a few in the middle. I'll make sure these slides are all available to you. If there's anything I don't expand and you're curious about, feel free to track me down, drop me an email, whatever. It's not hard to find me, and I would be happy to chat with people outside of here. So yeah, the topic today is working with chronic pain. Let me figure out how I advance. Okay, so here's the objective. So a few things. By the end, I'm hoping that you'll be able to summarize the difference between hurt and harm as it relates to chronic pain. I'm hoping that you'll be able to describe key limitations of symptom reduction approaches for treating chronic pain and to summarize kind of an alternative. And then lastly, to identify behavioral strategies and techniques from your current repertoire that can be easily adapted to help patients with chronic pain. Um, with Julie mentioning 2008, it kind of is giving me a bit of a flashback. In a previous life, I would have been giving talks like this on addiction, and I was sort of evangelizing, trying to get psychologists to be more involved with substance use treatment, believing that the vast majority of psychologists already have all the skills they need to do that work. But I know some people were sort of reluctant. And I never quite understood that. And then, of course, then I got into chronic pain work a few years ago, and I realized I was doing the same thing. I was sort of dodging chronic pain simply by not asking about it very much. It's just so common. And I think most psychologists already have the skills they need to work with it effectively. It's really more about repurposing what you already have and what you already do. So my hope is that we will it will pique your interest to do more of that. So I'm going to start with a quote here. This is from a nice National Institute for Health and Care Excellence out of the UK from early spring last year. One of the conclusions of a study they did and a review they did was that chronic primary pain should be managed with a few things: exercise programs, CBT, ACT, and acupuncture. And really had some pretty lukewarm things to say about the role of medications for managing chronic pain, sort of suggesting this paradigm shift is really occurring pretty quickly under our feet, driven partly by the opioid crisis, of course, but also just that opioids for chronic pain treatment really have not very good data to support it. So the behavioral care is sort of really center, and hopefully will become more and more so as time goes on. Of course, it begs the question of who the heck is going to do all that work. We don't have enough specialty clinics. The clinic where I was working at Mercy, the Living Life Well program, doesn't actually exist anymore, and they really kind of contracted what they're offering. So there's not a lot of good multidisciplinary full service pain treatments in really any part of the country, certainly in Maine. So other people need to step up, and I'm hoping you'll be willing to do that. So here's a few organizing principles just to start us off. Um, First, that feeling states, including pain, have functions. This will not be new to any of you who are very behavioral in your orientation. Pain is functionally more like than unlike other feeling states. And so I'm going to compare pain to emotion states throughout this whole talk, partly as a way of inviting you to think about what skills do you already use to treat those and how might they be kind of repurposed for pain. Thirdly, for most patients with chronic pain, the most harmful response is to stop moving. So you're going to start hearing a lot of ACT flavor here pretty quickly. The avoidance of pain in some ways is more damaging than pain. In a lot of circumstances, once pain becomes chronic. And lastly, that your existing skill set for things like anxiety, depression, trauma apply pretty well with working with pain once you kind of see how that works. Few core concepts, and I'm going to try to cover all of these. I can't promise you that I will in the time that we have, but talk a bit about the functions of pain, explain what nociception is, how it is different than pain, differentiate hurt versus harm. And that language may be new to some of you, but I think once you have it on board, it's pretty easy. Differentiate acute pain from chronic pain, And lastly, talk a bit about central and peripheral sensitization. Again, this is going to be pretty cursory, but it's an important concept. There's not great normal English speak for these terms, and so I just use central and peripheral sensitization with my patients too. But understanding how they work is important. So here's a primer on how pain works and how it's different than nociception. So here's the usual situation, right? So you have, you turn your ankle, you have something happen to your ankle, you get an injury down there, where the lightning bolt is. So what happens from there? Well, we have these receptors, three kinds that are important for what we're talking about today: mechanical, thermal, and chemical, and they are exactly what they sound like. Mechanical pick up signals that are, touch, pressure. Thermal are hot and cold. And chemical is any kind of chemical, like an acid, for example, like an acid burn. More commonly, something like, if you're lying on one part of your body too long and the lactic acid builds up and you move away from that discomfort, the nociceptors are picking up on that and helping you move around. So those detect the signal. Signal shoots north, right up to the spinal cord. At this point, it just indicates a possible threat. It's just a signal. So think like telegraph signal more than anything else at this point. Now, if it's above a certain threshold, then it will be relayed by the dorsal horn up the spinal cord to the brain. And I say if there because there are a lot of circumstances where it simply isn't. It's not salient enough, or descending nerves coming from the brain can really shut down that signal pretty effectively in a lot of circumstances. If the person has more important things to be attending to, sometimes we just don't feel pain. And so at this point, it's just a signal going from a site of injury through the dorsal horn up the spinal cord to the brain. It's being received by the brain. So nociception is an input to the brain. At this point, this is not pain. You're not necessarily perceiving anything at this point, right? And this is a little counterintuitive because it seems to work like this, right? You turn your ankle and it seems like the pain is in your ankle, right? It shoots up to your brain. It's really not what's happening. So kind of focusing in a little bit here, zooming in a little bit, nociception is one source of input, but there's a lot of other sources of input: visual, auditory, other sensory inputs, anxiety, other emotions that are going on. Past learning is hugely important for interpreting what that signal is meaning. Cognitive interpretation of meaning, stress and other physiological activation, and many, many others. So there's a lot of inputs, nociception being just one of them. So this is kind of an important thing. Try to hang on to this point as I continue through the hour. So at this point, it's still not pain, right? Pain is when the brain decides there's threat. Again, this is inferred, and it's not conscious. It's not like you're sitting there deliberating. It's very, very quick, but it's inferred. And if the answer is yes, this is something worth paying attention to, now it's pain. And so this is the counterintuitive thing that is about this. It's very strange, and I think a lot of patients will kind of look at you skeptically when you explain this. Pain is an output from the brain. It's not an input. So it's a perception like any other, and it's overdetermined, very complicated. And this matters because the places we're going to intervene may not be with the intensity of the nociception. In fact, it's usually not. So let's talk about this. I want to get this out of the way very quickly because this is a big stumbling block. So does this mean pain is in your head? And I can totally appreciate, if you want to really get philosophical about this, how you could say, well, actually, in some sense, yes. I'm going to beg you to say no. Please, if any communication you're having with your patient could be interpreted as pain is in your head, pause, think about what you're saying, really question what the purpose of your next words are. Because anything that sounds like pain is in your head is going to be received poorly in almost every circumstance. It's not as empowering as you think it's going to be. And you can be right, but you could also lose them very quickly. And partly because people with chronic pain, truly chronic pain, have often got a lot of unsympathetic, not very compassionate treatments over the course of their lives. And so whatever you're about to say, try to rephrase it so that it can't be interpreted in this way. So here's the example that I like to use. It's a little provocative, but bear with me. So, the experience of pain during a heart attack or after tearing your ACL, those are also perceptions, right? So if you're in a situation where you're like, is this psychogenic? Is this somaticizing? Is this in their head, quote unquote? We tend to consider that option in those cases. We don't think about it when someone's having a heart attack or tearing their ACL, but in all those cases, pain is always a perception, right? We don't think about calling it, quote, in your head. And so we don't mention the in your headedness of pain in any of those circumstances. So question why you're framing it that way. I will say this, having worked at Mercy for 7 years, I'm not discounting that psychogenic pain is a real thing. I'm really not. And somatization is important. Um, but I would say having those in my head as I'm seeing patients proved to be not very helpful, quite honestly. I don't walk in wondering like a detective, is this psychogenic or is this quote unquote real? It's just not that helpful. So many cases that we used to think of as being psychogenic really are just chronic pain that is, sensitization has occurred either in the body at the location of the injury or in the brain. And it could be inflammation, it could be an immune response. It's a lot more complicated than we thought. But lots of people who got labeled as having psychogenic pain in the past probably didn't just have psychogenic pain. It probably was more this like a sensitization syndrome. So I would say the sooner we can wean ourselves off those ideas, the better. They don't have much utility in the room. So this is a weird situation. I mean, you ordinarily something being complex is not like good news, but I think with pain, there is a silver lining in the complexity, which is that there are more facets to this, including more that we can do something about. So that's the good news. We often can't affect someone's nociception very much unless we want to encourage them not to move around, which is not a good idea. We don't always have ways of targeting sensitization directly or inflammation, but we do have ways of targeting a lot of those other arrows that we're pointing in, learning, mood states, stress, those sorts of things. And so the complexity actually opens some doors for us to do more things. So again, looking at this, right, we have a lot to say about stress and physiological activation. We have a lot to say about anxiety and emotions, interpretations, of course, and certainly the learning piece, what they do from here on out can often really drive whether someone is going to be hobbled by chronic pain or whether they're going to have a pretty good quality of life later. How they respond to pain is key. And of course, you're helping them respond to pain in a more flexible way. So again, the complexity here is not all bad news and it's got a silver lining. So the good news is new learning can, even if indirectly and not right away, new learning can change how pain is experienced. When people learn what's really going on with their chronic ankle injury or their lower back pain or the headaches they're having, and they start to react less intensely and they experience it as less of a threat, pain is often experienced differently. It changes the perception. And again, this isn't news when we're dealing with something like trauma or panic, so it shouldn't be here either. So there's another parallel. Here's the bad news. The subjective experience of pain is very compelling and difficult to counter. So again, you're not trying to educate people into this new perspective. It's really going to be doing good therapeutic work where people are going to have an experience of, oh, this isn't quite what I thought it was. So let's talk about the difference between acute and chronic pain. And most of what I'm going to talk about today is actually chronic pain. And there's a really important difference between the two. So let's kind of think about it this way. When everything is going well under normal circumstances, this is sort of what happens. You have an injury, right? And it peaks, there's actual tissue damage to muscles or skin or connective tissues. And for a short period of time, the injury is, pretty active. But then as your body heals and you recover from the injury, ideally, pain more or less tracks that, right? That's what acute pain is. Your pain hurts while the injury is there. And again, maybe not quite as perfectly as those lines suggest, but pretty well. How is it different than chronic pain? Well, with chronic pain, something else happens. This is what happens. In chronic pain, the perception of pain becomes divorced from active injury. So you have good days and bad days. Bad days would be when the line goes up, and good days are when the line goes down. And sometimes it's obvious why. You went for a long walk, you did more gardening, the weather or something's going on external to you, and it's pretty clear why you're having more pain. Other days it's not, and of course it makes people do a lot of confabulating about why their pain is better or worse. But better days, worse days, and it can really become quite divorced from the actual injury. So this is what chronic pain is all about. Now, if you look at the literature on chronic pain, you'll often see this definition that really just talks about the duration. And again, for lots of reasons, this is a nice definition because if you're doing research or it's just a lot easier to talk about it in terms of duration and chronic, the chronic and chronic pain suggests duration. The problem with defining it this way is that it unintentionally reinforces this idea that chronic pain is just the same thing as acute pain, just lasts longer. And I think it's actually not true. And kind of the functional difference is really the important difference here. So a better definition, and one that we used at Mercy, that I use in my work now, is that chronic pain is pain that persists beyond expected healing. If you're only going to remember 6 words from this talk, remember those 6. Hopefully you'll remember more than that. And again, beyond expected healing, it doesn't mean the person is going to be healed 100% like they were before the injury, before they slipped their disc or broke their leg or whatever. It just means at some point when the expected healing has occurred, pain that continues after that point, we're going to call that chronic pain. This is probably not about the injury anymore. It's probably about something else going on. So here's one way to think about this. So acute pain is more associated with tissue damage, whereas chronic pain is really more associated with neuroplasticity, meaning changes at the cellular level and in the regions where injury occurs, spinal cord up to the brain, the whole nervous system. So the nervous system has adapted and changed, and that's probably driving the pain at this point. So one way to think about neuroplastic, because I know it's a mouthful, neuroplastic is kind of like the learning and forgetting it's happening in your nervous system and the biological correlates to that. There's a whole talk that could be had just on that, but I'm not gonna go off on that tangent. I already have like 50 slides. So anyway, so here's a little thought experiment just to kind of climb into, and I'm guessing probably half the people on this call have chronic pain of some kind. Not half, maybe a quarter, right? Or you will, sadly. Very, very common. But if you don't have chronic pain that you can relate to, just think about this from the point of view of the patient, right? So imagine this. So here's the circumstance. Think about it this way. Under normal circumstances, how do you know an injury is healing? Right? I mean, sometimes you can look at it, right? And you can see, okay, clearly it's getting better, right? But if it's not that superficial or observable, how do you know if an injury you had is healing, right? Probably you're inferring it from how it feels, right? So you're kind of relying on the perception, and often pain is really driving it, right? So think about this circumstance, right? So if this is what happens with the pain, right? You have something happens, you roll your ankle, you have a skiing accident, whatever, and then the pain gets really intense, but then it kind of comes back down, and over the course of a few days or a week, it goes away. What do you infer about the status of your injury here? Right? Probably you think, well, it's getting better, right? This is just sort of normal. You're kind of imagining that's happening. That's the inference. Because you don't know. I mean, you don't have an fMRI on your hand that you can kind of just go like this and say, oh yeah, my wrist is better. You're really inferring as best as you can from inadequate data. What about if you're in this circumstance, right? You slip on the ice, your back, you get this blinding pain in your back. It's a little better the next day, but then the second day, it's actually kind of worse and it's stiffer. And from that point on, the next days and weeks, it goes up and down and up and down and up and down, right? And it could be days, it could be weeks, it could be months, it could be years. What would you be imagining is going on kind of under the hood if that's what you were feeling? I would argue probably quite reasonably, you're thinking something is still very wrong there, right? You're imagining mechanically, or something is wrong with the tissues, the bones, something is going on. So it is like the most obvious thing. And yet I think sometimes when we treat pain, we forget this, right? Especially if someone's been labeled as, having psychogenic pain or being somaticizing and that sort of thing. We expect that somehow the doctor's reassurance is going to be sufficient. But if this was your actual felt experience, medical opinions be damned. I mean, that tends to eclipse everything else. And so it is pretty reasonable to think something is still wrong with my back. Even as, you've had x-rays, you've had MRIs, your doctor's saying everything's fine, your disc doesn't look any worse than, lots of other people who are walking around with no pain at all. But meanwhile, you get out of bed in the morning and you have this terrible pain. It's like a 7 out of 10, and it gets worse the more you walk. It's pretty hard to be convinced otherwise. This is the subjective aspect of pain that is very difficult to kind of push back on. And so you probably shouldn't push back too hard. All the more so if it lasts for a very long time. And chronic pain can last for a very long time, right? I mean, I've known people who have had chronic pain since they were 12 and now they're 60 and it's still pretty bad. So that personal experience will eclipse much of what they get medically. So in terms of what we can do about it, I would say start by thinking functionally. Go back to your functional analysis days when you were learning that in grad school. You may have to brush that off if you haven't used it recently. And start thinking about, what is it for? And again, I actually think this is useful to do with almost anything. When you start to get into a bit of inertia with your practice, as we all do, we're all human, right? And you get a little rusty or you get a little stale with things, to go back to kind of the drawing board. whatever it is you're dealing with, whether it's anxiety, low mood, or something more, so-called physical, like a fever or inflammation. What is it for, first and foremost? Before we start treating it as a symptom or a problem or a disorder, what is it for? Like, what is its job? And I think about it from an evolutionary perspective. Even if you have to speculate a little bit, it can help you kind of climb inside the function a little bit. We don't have these states just for kicks, right? Most of them have real jobs to do before they become a symptom or a problem or disorder. And it's clearly true for pain. So let's just talk about that for a minute. Again, if I was in the room with you all, I'd do this more interactive, and since I'm not, I'm just going to blow through it. Think about what pain is for. What is its job? Well, to warn us of an injury, of course, right? But then even more than that, to prevent an injury or prevent an injury from getting worse. So, if you have an active injury to your bone, if you break your leg, you probably shouldn't be putting your weight on it, right? For the most part. And so that pain is trying to create a condition for you to heal, right? And it's giving you some feedback on whether the healing is actually happening. So prevent worsening. At the end of the day, it's a survival mechanism, just like anxiety and fear and lots of other mood states and emotion states. It's there to allow an organism, whether it's human or not, to avoid making an injury worse, and also to learn from it, right? Because we know that intense feeling states tend to potentiate our learning quite a bit. So it is, by and large, a survival thing. So, and again, even this little nugget is often news to people, right? So when they have patients don't often think about, I asked patients when I was running groups at Mercy, like, ideally, how much pain would you have? It's a trick question, right? And they would say, what do you think they say? They all say, well, none, right? Obviously, that's what we all want. But in some weird way, that's actually not the right answer, right? Because to have no pain is not to be moving around the world very much, right? Because you're going to have some pain no matter what you do. And there are people who have genetic conditions where they don't feel pain and they don't actually do very well, right? Having neuropathy in your feet is not that great, right? You have to manually check the bottom of your foot to see if you have injuries. Otherwise, you might get, infections. There's a genetic condition where people can't feel pain. They don't perceive pain. And this is sort of a joke, sort of not a funny joke, but like a play on words or something. You can often identify these people because they're like missing fingers and things. Like, it's not a good thing. It's not something to envy. And so zero pain is not really the goal here. It's a very useful system. Just like zero anxiety or zero fear would be a bad idea. Now I really am getting off on a tangent. Okay, come on back. So here's sort of a provocative question that I'm not going to answer entirely or adequately is pain an emotion? So just digest that for a minute. Whatever you say, whether it's yes or no, could you defend it? If we put you on the spot right now and made you defend that in front of all your colleagues, it's a little confusing, right? Because I know my first instinct is to say, well, no, it's different than emotions. But if I had to argue why it's not an emotion, it's actually kind of hard to do. The instinct is to say, well, it's more of a bodily thing, right? But then you think about an example like panic. Is pain more or less physical than panic? If you've ever had a panic attack, right, and at least half of you have, so that's a few people, right? It's a pretty physical experience, with your heart beating and your stomach churning and the sweating and the hot and the shaking and the adrenaline. That's pretty much a bodily experience, right? Pain is very much like that. It's also, it's something your nervous system is doing something. It's easily measurable if you're hooked up to the right instruments. But you could almost make an argument that there are many situations where pain is not very much of a physical experience at that moment, especially chronic pain. Whereas panic, it's almost always a physical experience. So, and again, I'm not going to answer this. Some people will say, yes, pain is an emotion. Other people know. And I think you get into a lot of, word juggling and philosophical debates I'm not really interested in having right now. But I'm just introducing the idea to make you question whether you categorize this in some significantly different way. Because again, part of the premise here is that it is more like than unlike other feeling states. I've already said that. All right. That being said, I would say, even if you don't think of pain really as being an emotion, that's fine. You don't have to get on board with that. Very clearly, part of pain's power is emotional, right? There is a panic-like response when you have pain, especially if you have chronic pain. And you've learned that, aggravating your back might mean that you're out of commission for 3 weeks or 4 weeks, and you've got kids to chase and work to go to or a long trip to make. Part of pain's power is emotional. We worry about injuring, re-injuring if you have chronic pain. And when it shows up, it grabs you like panic or fear. And so there are layers of emotion wrapped around it, if nothing else. It certainly functions like an emotion in terms of grabbing your attention, putting that attention towards some kind of threat, motivating you to get away from it. Feels really good to get away from it. So there's negative reinforcement going on there. So in a lot of the ways, it functions like an emotion, even if we decide ultimately that it's not really an emotion. And so the good news of that is that you can treat it, at least in part, like an emotion. Again, the reason why this is good news is because you already have skills for that, right? And so many of them are going to apply here quite directly. Now, I wouldn't encourage you to sell this to patients. This is not something to like lead with. No, pain is just like an emotion, it's like anything else. I think you're going to lose people pretty quickly, just like saying it's in their heads. But you could use this as you're conceptualizing what you're about to do, and as you consider different ways of intervening and helping people. It's very useful to have this in your head at least. So here's an example, like a hypothetical interaction with a patient. So Ms. X, we have two goals here. Do every reasonable, meaning healthy and safe, do every reasonable thing we can to reduce your pain and make it manageable. There's no reason not to get on board with that, right? We do want to help people reduce their pain if they can, keyword being safely. And we want to limit the negative impact that pain has on your life. And I'm not advocating that you do a bait and switch and like swap your goal for theirs, right? Because that's not client-centered care. But I would say I think it is fine to smuggle that in as quickly as you can. Most people are in agreement with it anyway. They're not necessarily thinking about it that way because pain is so salient and so front and center that they just want to get it to go down. And they can't imagine life being better with this level of pain. And it's a failure of the imagination, but it's one any one of us could easily do. Because pain, again, is very compelling. So we want to smuggle this in early. We want to limit the negative impact that pain has on your life. If it's already had a huge impact, if their life has already gotten pretty small from chronic pain, then we even want to say it more boldly, is we want to really reverse that if we can. We want you to have a larger life, a bigger, richer, fuller life, even if your pain doesn't go down. Hopefully it will. We'll try. We'll do everything we can within reason, right? But we're really looking at quality of life here too, in a big way. It's not a secondary goal. And you might even add this, in a perfect world, we would do number one first. We would reduce the pain and then we'd help you get your life bigger. That's what they want. That's intuitively what makes sense. It's just that sometimes what makes intuitive sense and what actually works don't line up. And this is a case where they don't line up. Because in some ways, the work is to make people's lives bigger. And in the process of doing that, you can kind of marginalize pain, or sometimes it actually becomes less. But you can't always reduce the pain first, because the things you would do to reduce the pain first are take more meds, move less, give up activities that make it worse. And most of those are not a great idea, right? So in this world, when we act, the one in which you already have chronic pain, we really need to work on these goals at the same time, right? So you're broadening the target like right away. So let's get to some specifics finally. So single most useful concept, and this isn't just my opinion, when we would have people go through the 10-week program at Mercy, we would do lots of feedback forums and all that kind of thing. And very, very often what patients would say was the single most useful idea was this one. The idea that there's a difference between hurt and harm. This is a very simple way of talking about some of these more complex issues we're considering here. So what is the difference here? Hurt is the felt sense of pain, the subjective experience, that perception of pain is hurt. Harm is damage to bodily tissues, to your disc, to your ACL, a cut, whatever. To have these two ideas in mind. And again, the problem, here's the challenge. Subjectively, they don't feel any different at all, right? And I've actually done, again, when I talk about this with groups, I say, well, how do you know whether it's hurt or harm? How do you know whether this is pain that's gotten worse because you've moved, you bleed gardened for 2 hours and you haven't done that in a while, so now your back pain hurts more, but there's no injury, there's no exacerbation of your injury at all? How do you know if it's that, or how do you know if maybe you actually injured yourself? And again, it's sort of a trick question also, because usually at that moment, you don't really know. You can't infer this from the quality of the pain. Now, let me qualify that actually. Sometimes you can, like a new pain, a pain that is suddenly much worse. Yeah, sometimes you're like, ooh, I really injured myself again. But when we're talking about chronic pain and those kind of the waves, the ups and downs of it, most of the time when your pain is getting worse because you've moved around more, it's not clear from the signal and from the perception that it's injury. And so just having the idea in mind is important. And you're going to help patients have the experience of the distinction, not just kind of teach them this. You do have to teach it, otherwise they don't have the language for it. But as you're talking to them, start to have them sort between hurt and harm. Even if they're wrong, even if they're like not sure, it's still worth starting to consider it. Before they stop doing something because they're pretty sure they injured themselves. Is that hurt or harm? Let's kind of think it through. And how you'll eventually know whether it's hurt or harm is through experience, trial and error. Nobody with chronic pain wants to hear that, but it is the reality of it is, if their pain gets worse from doing yoga or walking or picking up their grandkid, and the pain is like lasts maybe a day, and after like 36 hours, their pain kind of comes back down to normal. That was probably just an exacerbation of pain. It probably was a hurt, not a harm. So they're going to start to kind of figure this out through a lot of trial and error. And again, that feels not very scientific or very medical, but frankly, it's better than the alternative, which is that you just stop picking up your kid and you don't garden and you don't walk anymore. And so the trial and error process, you just kind of evolve a different understanding of what is hurt and what is harm, kind of up here, and you kind of know it. You learn what you can and can't do through experience. So lessons from psychology. This is sort of one of these truisms that I think, you can get a lot of mileage out of this in psychology. Approach what you would avoid. Think about instinctively what you're inclined to avoid and consider approaching it. Now, we're not talking about approaching injury. We're talking about approaching pain, right? So the disclaimer is this. You're not just doing like pain exposure for no good reason. You always have to have it very closely hitched to a purpose. So needless pain, there's no value in needless pain. No mammal, no self-respecting mammal moves toward pain just for on their own. Well, there's probably a few exceptions to that, but like for the most part, we don't do that, right? So yes, we want to avoid harm whenever we possible, but here's the thing. You have to kind of consider the counterfactual here a little bit. Consider the harms of not moving. Consider the harms of avoidance. Again, this is why ACT is such a good fit for working with pain, is because that's kind of built in to ACT work, is we're looking at behavioral inflexibility and avoidance, and those are our kind of targets. So when you're deconstructing the pain experience, I'm going to blow through these a little bit too quickly. You could have people do behavioral experiments where they actually cause pain in their bodies that you are very confident is not an injury, just as a way of kind of watching how they react and respond to it. Kind of like when you're doing something like interoceptive exposure for panic, right? You can invite me back if you want me to expand on that. So, and this is kind of how we do it. We study pain in the labs using cold pressor tasks where you make people cold and they feel pain for it. And you can do things like mindfulness of pain. As counterintuitive as that seems, it can be very helpful to kind of help people soften their reactions to their pain and to have more openness and awareness to it. So we're trying to help people have pain in the service of something else. Well, in service of what? Well, engaging in recovery activities that may alleviate the pain in the long run, like exercise, right? Continuing to engage in healthy activities they haven't lost. That's really important. This is why it's good to get people early if you can. Protecting valued aspects of their lives, things like work, spending time with family, hobbies, things that give them a lot of richness and value. You want to help them take a stand to not give up those things if at all possible. Now, you might need to help them make accommodations and change, pace themselves, do things differently. But as much as possible, we don't want people to be throwing their valued activities and roles overboard. Because when people's lives shrink like that, getting it big again can be very hard, as we all know. We're really focusing on quality of life here. What else? In the room, once you gain some comfort with working with this, you could really kind of help people transform their pain experience. Again, as by way of analogy, think about how you transform a panic attack. When someone becomes willing and open to having a panic attack, and that is a huge tipping point therapeutically, right? They're going to come in the room and they're going to sit down with you and you're going to have them breathe through a straw until they trigger a panic attack. You're basically triggering the suffocation alarm in their body and they have a panic attack, but they're doing it on their time in a safe place with you sitting there, and you don't hurry it away. You help them write it out, come out the other side. They don't lose control. They don't spiral. Nothing bad happens. They don't burst into flames. They kind of come back down. Well, you could do this in small ways with pain. And this is really a way of transforming pain. You're helping people interact with the pain, coexist with it, really decouple it from their automatic actions. So this may sound a lot like ACT diffusion or flexible perspective taking, right? Helping people have an experience of anxiety or fear or low mood or have depressive thoughts and not have that experience organize what they do, right? That's one of the keys targets for ACT. One of the things that really generates a lot of get a lot of bang for your buck for that. And then link next actions to more workable long-term strategy. How do you keep people moving? What else? Well, you want to help them experience pain in safe situations. Help them experience pain when there's clearly no threat. In the office for homework, and you want to generalize it to all sorts of other circumstances, right? If they can only do it in the office, it's not so useful. So you want to get people to be able to have pain. And again, you're not provoking it needlessly. It's all for something. Keep the values piece close. This is the ACT piece again, right? You don't do trauma exposure work unless you know the value is like, why are we doing this, right? Keep that very, very close in the room all the time. And people can do kind of pain exposure. So here we are again. Again, looking at these different inputs to the perception of pain, we can actually affect quite a few of these. Again, with the skills you already have. And you can basically, you're creating a lot of new learning. We can celebrate the fact that humans are the only animals that can kind of like, we can push ourselves in the direction of a new reinforcement schedule, right? With reinforcers and punishers, we know where they are, and have new learning. You can have new habits in a month or 2 or 3, and that's great. That's the good news. You can kind of help people become flexible in the face of pain, even if their pain isn't targeted at all. Now, the good news is when they get moving, their life gets bigger, their pain often comes down as sort of a side effect. Again, same punchline we experience with ACT over and over again. So, a couple things to kind of notice. Part of what makes this difficult is that when people have pain, like when they have panic, it really hijacks people's attention. And so it's not uncommon for people with chronic pain to say things like, I can't read anymore. I read a page and then I'm off and I come back and I read it again. And like 5 minutes later, I come back and I'm like, God, I don't remember what I read. And like they're talking about having like attentional impairment from their pain. And it's partly because their back is throbbing or their head is throbbing, right? Now, we tend to think about this as yet another problem, but actually, in some perverse way, it's actually not, right? This is a feature of pain. This is how it's supposed to work. Pain is supposed to say, like, I don't care what you're doing, right? What you think is important isn't important to me. We're in danger over here, right? I'm being stabbed, I'm being bitten, something's wrong. Your appendix is about to burst. You don't get to override that and go read a book, right? your pain system, if it's working well, is saying, you're going to focus over here because something's wrong. Your head's on fire. Deal with that first. And so many of the side effects of chronic pain are really features, not bugs. Doesn't mean you can't help people deal with them. This is why mindfulness can be really super useful here. But blindness to the other costs, like a lot of people don't have a great appreciation for how much their life is becoming impaired or impoverished by the fact that chronic pain has taken over their life. I mean, managing chronic pain becomes this central organizing task of every day. And again, whether it's depression or anxiety, we know what this looks like, right? It's a terrible way to live. And so partly what we're trying to do is we're trying to have other parts of their life that are important and rich and meaningful compete with pain, essentially, for their attention. Sounds a lot like depression work, right? If you're doing behavioral activation, you do the same kind of thing. So a few words about how to think about generating pain-related goals, right? It's not just about reducing pain. So here's some questions you can ask yourself while you're sitting with patients. What is the cost of allowing pain to continue organizing this person's life? And again, you're having these questions with the patient. Maybe in language, it's a little bit easier. Can we expand this person's responses to pain? How do they respond to pain? In 1 or 2 or 3 ways? Can we get that to be 8 or 10? Can we change this person's relationship with pain? Again, this is sort of an ACT angle on things. What multiple factors are contributing to this person's pain? It's not just the gardening. What else is it? What factors are amplifying this person's pain? So what else is going on? Stress, not sleeping well, eating poorly, all these other lifestyle factors. We know most of them are related to experience of chronic pain. What responses to pain are adding to this person's pain and suffering, right? Suffering from an ACT lens is often pain plus the unwillingness to have that pain really amplifies people's suffering. What responses to pain and suffering are interfering with this person's healing and recovery? One of the things we did at Mercy that was really helpful was we had a yoga kind of gentle exercise class right in the program. So people would go to group with me, and then you go right to yoga afterwards. And they often were very scared to do that. And so they would deal with their anxiety and fear and avoidance of pain too. It was very highly adaptive to what their body could do. And often for the first few weeks, their pain increased. Talk about a bad sell, right? I mean, it was very difficult to keep people on board with that. The overwhelming majority, after like 3 weeks, 4 weeks, 5 weeks, their pain came down. And they often would come in expressing surprise at what they could still do. Like, I didn't think I could touch my toes again. And I just did, and that kind of thing. And again, it's way more compelling than anything you could say or teach, is to have them to have that direct experience of it. So let me compare it to a few other things you already treat to give you an idea of what does it look like to treat pain. So I'll bet many or most of you deal with panic at some point, right? You treat that. So from an ACT perspective, what do? Before treatment, people's primary way of coping is avoidance and escape, right? This is what panic has you do. Also a feature, not a bug, right? It's supposed to do that. After treatment, they still avoid and escape. But they also do other things. They use a relaxation exercise you taught them. They engage with mindfulness. They write it out. It's like urge surfing kind of thing. They learn to write out their panic. They learn how to provoke their panic in situations where it's safe and therapeutic and helpful, right? And they change their relationship by approaching what they would avoid. So from an ACT perspective, this is the outcome we want. This is psychological or behavioral flexibility. It doesn't mean they're doing the right thing. It means they're doing more things. And from there, what works will get selected and will rise to the top. And what doesn't work will eventually be left behind. Consider another example, substance use treatment, right? So somebody comes in with a substance use disorder, drinking, using substances. So before treatment, they were stressed, they're upset, they have a hard day. What do? They drink or they use, right? This is the rigid response we're targeting. After treatment, they might still use or drink, actually, right? We don't always eliminate that. But they may also do other things. They may engage in some of their relapse prevention skills. They might use mindfulness. They might do urge surfing. They might do some kind of replacement behavior. They have a piece of chocolate. They go read a book. They call their sponsor. They go to a meeting. They do all sorts of other things. And so their menu is bigger. And again, that's behavioral flexibility. And once they throw that in the world, the options that work will get selected, and the ones that don't will get left behind, hopefully. People evolve out of that stuck situation, right? And so pain, here we are again, right? They avoid or escape, or they hyper-focus on pain. Those are two things to do before treatment. How about afterwards? Well, they might still avoid or escape, but now they might do some kind of modified movement or gentle exercise. They might do a mindfulness of pain exercise. They might learn how to sort of allow, which is kind of like acceptance by a softer name, right? How to be open to the pain, how to engage in pacing in a smart way so they can keep activities that are important to them. And they have an awareness of the cost of heeding the pain, meaning if I allow this pain to organize what I do for the rest of the day, what is that going to cost me? So that cost starts to have some real substance to it. And it can affect people's decision making once they really can kind of factor that, bring that kind of counterfactual in. So again, we're trying for behavioral flexibility here. So your role has changed from a narrow focus on reducing pain to this one. And this is kind of what you're thinking or saying toward patients. Given that you have chronic pain, how do we retain as many valued and purposeful activities as possible? So I'm going to point you to a few resources, and then I'm going to pause and let you ask any questions you have. Some really good resources out there now, and they're kind of multiplying quickly. So Lorimer Moseley is an Australian PT, and he's really kind of a joy to listen to. So that makes it easier. You can find some of his videos and talks online, but he has these 3 questions, because part of the issue here is that even if you change your language in thinking about chronic pain, most of these patients are embedded in a healthcare system where they may or may not be getting a different message. Now at Mercy, that was the beauty of it. Steve Hull, the physiatrist there, this was his baby too. And so it was easy to communicate with him. But with most physicians, they're not necessarily thinking about it in these terms yet, although they're often further down this than patients realize. I will say that. And so you're often doing is you're giving patients a behavioral experiment to go back to your doctor and ask them some real specific questions about the kind of pain you have. Here are some of them. How do I know if or when my pain system is being overprotective? It's being a little too zealous in its efforts to keep me safe. How do I know if that's happening? What can I do to train my pain system to be less protective? right? It's like a smoke alarm that goes off whenever you burn the toast. Is there some way to fiddle with the sensitivity so that I'm not always waking up like, terrified like that? Am I safe to move? Many of the patients I work with, when I ask them, what does your doc say about whether you should keep moving or not? They often look like, I'm not sure. And that's interesting because I actually know a lot of physicians now, and most physicians are saying, you got to keep moving. Go to PT, keep exercising, do what you can, adjust it if you have to, but really keep moving. So most docs are giving this message. So part of my main job now is I talk to family medicine residents and staff. And so I'm trying to help bridge this language we're using with the language they already use to try to make sure that patients are very clear about this when they leave the office. That being said, many will leave without this clarity. And so you're sending them back to their docs and their PTs with these questions. What do I do if my pain gets worse when I'm doing this? Is it pause, take a break, put some ice on it, come back to it tomorrow? Because the default response is you do something, your pain goes up, you give it up, right? Pain is punishing, and so you do it less afterwards. And so we want to push back on that a bit. So I'll come back to the Q&A and I'll ask you can ask whatever questions you want, but let me just say one more thing real quick. I'm going to sort of page through these slides just for the sake of people who might only see this on video. So there's some good, this is just the article at the very beginning. Here's some good links to resources for Lorimer Moseley, and I'll make sure that you have these slides so you can just click on the link. Some good talks. There's a few Act for Pain books out there that are pretty decent. Lance McCracken, that second one, if you want to look at some literature, Lance McCracken is doing really great work on contextual behavioral treatments for this. And that's where I'm going to pause. I can't believe I got through all those. Goodness. So any questions you have?
Not a question, Joel, but just